Welcome to Wysdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
If you're looking for the quickest way to really get up to speed on complex medical literature, well, you're in the right place. Today we're focusing on a pretty critical interventional procedure, bronchial artery embolization, BAE for short. This is really the heavy hitter they use to stop life-threatening hemoptysis, coughing up blood, often in patients with really severe chronic lung diseases. So our sources today give us two different but equally high-stakes angles. Our mission basically is twofold. First, we're going to look into the long-term effectiveness, the staying power of BAE in a really complex group, adults with cystic fibrosis or CF. And second, we're digging into this huge data set to figure out the actual prevalence and, maybe more importantly, the specific risk factors for BAE's most, feared complication, spinal cord infarction.
Yeah, and to really appreciate why BAE is even necessary, you have to grasp how serious hemoptysis is in CF patients. I mean, this isn't just a little bit of blood in the sputum. We're talking about potentially fatal bleeding. While maybe 9% of CF patients experience some hemoptysis, about 4.1% experience what's called massive hemoptysis. And that's defined as anything over 240 milliliters. That's roughly a cup of blood coughed up in just 24 hours. It's a lot.
Wow.
And the underlying reason, the pathology driving this, is key. CF leads to this progressive disease state, right? Chronic inflammation, constant infections. And this makes the lung desperate, basically, for a better blood supply. So it starts recruiting systemic arteries, often from outside the usual lung circulation. And this leads to these incredibly fragile, abnormal vessels. When those break, BAE is often the only thing that can stop the bleeding.
Okay, right. So let's unpack that first study then. We're looking at research from Stanford, spans 17 years. And you said this wasn't just like a routine update. It was really needed. Why were those older studies on BAE and CF, the ones from 15, 20 years ago, suddenly not good enough?
Well, because the whole landscape of cystic fibrosis treatment has fundamentally changed. It's just different now, thanks mostly to new drugs, especially CFTR modulators. The lifespan for these patients has shot up dramatically. We're now seeing adult CF patients living much longer, often well into their 30s, even 40s. So those older studies, they just couldn't account for this longer lifespan or the complexity of managing bleeding in older patients who have more severe long-term lung damage. The Martin study we're looking at, for instance, specifically focused on adult CF patients. Their average age was 32. So digging into the details of that Martin study, it covered 2001 to 2018. They looked at 38 BAE procedures done on 28 adult CF patients, and they needed very clear ways to define success in such a difficult patient group.
Right. You can't just say it worked.
Exactly. So they used two main definitions. First was technical success. That was defined pretty narrowly. Basically, freedom from needing another embolization and not dying specifically from the hemoptysis itself. Then there was clinical success. This was broader and, frankly, a bit more stark. Freedom from repeat embolization and mortality from absolutely any cause.
Okay. And when you look at those technical numbers, BAE seems to really perform. I mean, despite how destructive CF is, the initial 30-day technical success was, 89%? That's 25 out of 28 patients. And the long-term results held up too, right? 3-year technical success was still 82%. Even the tougher measure, the 3-year clinical success, was 75%. So it seems like BAE is really effective at stopping the bleed and keeping those specific vessels closed.
It is, technically speaking, but here's where we really need to pause and look a bit deeper. You highlighted that impressive 89% technical success at 30 days. Absolutely. But that success rate stands in really sharp contrast to the patient survival data. The overall 30-day mortality rate was 14%. 4 of those 28 patients died within a month.
Wait, hang on. How does that work? If the procedure itself was technically successful 89% of the time, how could the 30-day mortality be 14%? What does that tell us? Is it about the severity of the underlying CF versus the BAE procedure itself?
It tells us something absolutely critical in medicine. Technical success doesn't always equal clinical cure, especially not in a disease like CF. BAE is fundamentally a life-saving procedure for an immediate crisis, the hemorrhage. But it doesn't and can't solve the underlying problem, which is often catastrophic respiratory failure from the CF itself. And the causes of death really bear this out. Of the 7 patients who died within 3 years, that's a 25% 3-year mortality rate, by the way, only 1 died directly from another massive bleed. 4 patients died from progressive respiratory failure. So it really underscores that BAE is buying these incredibly sick patients critical time. It manages the bleeding crisis, but they are still profoundly ill because of their systemic condition.
Right, right. Okay, shifting focus a bit to the procedure itself in that study. The clinicians were, well, pretty aggressive, but it sounds like they had to be. 60% of the BAEs were for massive hemoptysis, and they were embolizing on average like 3.4 vessels per procedure, sometimes up to 8.
Yeah, and this aggressive approach actually reveals what might be the study's most significant practical finding, sort of the aha moment, about vessel targeting. They discovered that almost 75% of the BAE procedures, that's 28 out of 38, involved embolizing non-bronchial arteries.
Non-bronchial arteries, so extrabronchial arteries, vessels coming from outside the main lung supply system. That fits perfectly with the pathology you mentioned earlier, the lung basically hijacking systemic blood supply because of the chronic inflammation. It almost sounds like if you only target the main bronchial arteries, you could be missing the actual source of the bleeding in, 3 out of 4 patients?
Yeah, that's exactly it. And this is particularly pronounced in CF. If the operator doesn't actively look for and treat these abnormal, systemically recruited vessels, like the internal mammary artery, which is the most common non-bronchial target they found, then the procedure is just likely to fail. The patient will probably rebleed.
Wow. And this insight actually led to a real-world change at Stanford, right? A policy change. Since these non-bronchial arteries were clearly so critical for success, they set up a multidisciplinary policy in 2014. What did that involve?
It basically mandated proactive, detailed mapping beforehand. It required that patients who were going to have BAE needed to have a CT angiography of the chest done within 6 months before the procedure.
Yeah.
So this policy shifted BAE, at least at their institution, from being primarily a reactive emergent procedure, where the operator is scrambling mid-bleed to find the source, to being a more proactive procedure where they already have a kind of roadmap. They know which systemic abnormal vessels they need to carefully check and potentially embolize. That's a huge shift for safety and effectiveness.
Definitely sounds like it. And just quickly touching on overall safety in this very high-risk CF group, the complication rates themselves seem pretty low.
Yeah, reassuringly low, actually. The overall 30-day complication rate was just 7.9%, and the major complication rate was very low, only 2.6%. The one single major event was a blood clot, a thrombosis in the common femoral artery at the access site, and unfortunately that did contribute to that patient's death. But the vast majority of complications were minor things, like temporary chest pain or some transient pain when swallowing. So the data really suggests that if you can get the patient stabilized, the BAE procedure itself, especially in an experienced center, carries a predictable and relatively low risk of bad side effects.
Okay, so the CF data gives us some confidence in BAE's effectiveness, especially if it's optimized with that proactive imaging, finding those sneaky non-bronchial arteries. But even optimized procedures still carry risks. And that brings us to the absolute worst-case scenario. So now we transition to our second piece of work today, focusing on that really rare but absolutely most feared complication, spinal cord infarction or SCI.
Right, and to accurately study something that might only happen, once in maybe 1,000 cases, you need enormous numbers. You just have to. And the Ishikawa study delivered exactly that. It was a huge nationwide observational study in Japan using administrative claims data. They analyzed records from 8,563 patients who had BAE over a 9-year period. Massive data set.
And the headline finding there is just how incredibly rare this catastrophe actually is. Across almost 9,000 procedures, the overall prevalence of SCI was only 0.19%. That's just 16 patients in total who suffered this awful complication. Before big studies like this, I bet a lot of clinicians probably thought the risk was higher just because those cases, when they happen, are so devastating and memorable.
Yeah, the low prevalence is definitely a comfort, statistically speaking. But, for the individual patient, a 0.19% risk doesn't mean much if they happen to be that one person who ends up paralyzed. So understanding the mechanism is absolutely key. We know SCI happens because the blood supply to the spinal cord gets interrupted, basically.
How does that happen during BAE?
Well, it seems to happen in two main ways. First, the embolic agent or whatever material is used to block the bleeding artery can reflex. It can flow backwards towards the aorta and then accidentally get into a major vessel that feeds the spinal cord. Or second, you can have unintended, non-target embolization. This is where the particle or the agent flows forward like it's supposed to, but because all these arteries are interconnected in complex ways, it travels through tiny connections and ends up blocking the anterior spinal arteries downstream. It's essentially like a plumbing problem that unfortunately leads to tissue death in the spinal cord.
Okay, so if the mechanism involves the agent itself moving where it shouldn't, reflexing or migrating, then the actual physical properties of the stuff you use to embolize must make a huge difference.
Oh, profoundly, yes. And that was the most crucial finding, really, of the entire Japanese study. The risk of SCI varied significantly depending on the specific embolization material used, and this wasn't like a borderline finding, it was statistically significant, a real difference in risk.
Okay, maybe let's quickly define these materials before we break down the risk numbers, because how they behave physically seem central here.
Good idea, yeah. We're mainly talking about 3 types in this study. First, you have coils. These are tiny, permanent devices, usually like little metal wires. They're placed very precisely by the tip of the catheter, so highly controlled placement. Second, there's gelatin sponge, GS particles. These are temporary particles, kind of like tiny bits of sponge that get injected into the bloodstream and basically clog up the vessels. They rely on blood flow to get where they need to go. And third, there's N-butyl-2-cyanoacrylate, or NBCA. This is essentially a liquid glue. It solidifies almost instantly when it hits blood, forming a rapid blockage in the artery.
Okay, that context is super helpful. Coils are placed precisely, particles flow with the blood, and NBCA is a fast-acting liquid glue. Now let's see the risk data related to those.
All right, so the NBCA group, the liquid glue, the one you'd think has the highest chance of refluxing or migrating quickly, that group had the highest prevalence of SCI, 0.71%. That was 3 out of 425 patients. The gelatin sponge particles, the flow-dependent ones, were in the middle. Their prevalence was 0.1%. That's 12 out of over 6,500 patients.
And then the coils. The mechanically placed controlled devices.
Lowest by a huge margin, just 0.06%. Only 1 patient out of nearly 1,600 who got coils had an SCI.
Wow, 0.06%. That's more than 10 times lower risk than the NBCA glue group.
It's a striking difference, isn't it? And the theory linking this data seems pretty strong. Coils allow for very controlled embolization. Because the interventional radiologist places the coil exactly where they intend it to be, they minimize the chance of that material flowing backward into the aorta or flowing forward unexpectedly into the spinal cord's vascular network. The liquid agents, and maybe to some extent the particles too, but especially NBCA, they're just inherently harder to control perfectly once they leave the catheter tip and enter the bloodstream.
It really seems like, based purely on the specific complication risk to SCI, that coils would be the way to go, right? But then you look at the usage trends in Japan during the study period, 2011 to 2017. Gelatin sponge particles were still the main agent used, like 78% of the time. And coil usage actually went down slightly over that time, while NBCA use, the one with the highest demonstrated SCI risk here, actually doubled from about 3% up to 6%. That seems counterintuitive.
It does seem counterintuitive based solely on the SCI risk, yes. And it really highlights the complexity of clinical decision-making in real time. While this data strongly suggests coils are safer specifically for preventing SCI, there are other factors and potential trade-offs. Coils can sometimes be slower to deploy, maybe more technically tricky in very small vessels. Liquid agents like NBCA or maybe particles might be felt to be necessary when incredibly rapid blockage is needed, like in a truly massive life-threatening hemorrhage or in certain vessel anatomies. But this data certainly forces a very hard look at that calculation, that balance between perceived speed or ease of use versus the documented safety profile, especially considering such a devastating outcome.
Okay, so let's try and synthesize this for everyone listening. What does this all mean for you? Putting these 2 deep dives together gives us, I think, a pretty powerful conclusion about achieving excellence in BAE. The CF study shows us that BAE can be remarkably effective for long-term bleeding control, even in these incredibly sick patients, if you optimize the procedure. Specifically, by proactively identifying and treating those non-bronchial arteries, which often means getting that pre-procedure CT angiograph.
Exactly. And then if we connect that to the bigger picture from the Japanese study, that massive data set on SCI really shifts our focus from where you embolize vessel identification to what you embolize with material selection. The data strongly suggests that the choice of embolic agent has a direct measurable impact on patient safety, even when we're talking about complications that are, thankfully, very rare. It really demands we critically appraise our standard practices.
Yeah, which raises a really important question, doesn't it? We saw that coils appear to offer by far the lowest risk of spinal cord infarction, yet they were used in only a minority of cases in that huge Japanese cohort, about 18%. And the clinical usage trends didn't seem to reflect the safety data that this very study uncovered. So the provocative thought to leave you with is this. Considering that significant more than 10-fold difference in SCI rates between coils and NBCA, how might, or perhaps how should, findings like these influence global clinical guidelines, specifically for selecting the first-line embolic agent? You're given those pros and cons we touched on, controlled mechanical placement versus potentially faster particle or liquid agents. That safety versus speed or ease of use equation now has some pretty powerful evidence behind it. Definitely something worth mulling over.
This is Dr. Rusty Hoffman, and that's a wrap from Wysdom Radio. Find cutting-edge insights through our rapid-fire videos and community forum at medicalwisdom.ai. And remember, knowledge is the best medicine.